So whenever you have this issue that a post-CABG patient has presented with some kind of coronary problem, issue is whether to open the grafted vessel or to go for the native vessel. Most of the time, this issue presentation is say 8 or 10 years later. So grafts are also old, and native vessel, because there is no flow through them, have progressed and probably completely occluded. So both ways we are in a tricky situation. So this is the ischemia study 2 years back, and losers were high-risk PCI, big time loser, and these were high-risk patients. This, of course, would be loser either ways. If you send them for repeat surgery as well as PCI, but the high-risk procedures like the PCI in these individuals is high risk. So which part to go? This is a very important issue. So first, thinking, can we manage this patient medically? I mean, like in this case, you have a Lima graft. This area was stented. There was an ISR. There was a restent. And this is flowing well. So a sizable circulation is occluded. And this Lima, however, is very good, but there is a disease in the native vessel beyond the Lima. And this Lima was actually flying retrograde to this area. So this vessel, if you have to stent, you have to be very particular, perfect, and end up with a very good results. So this is actually the rosy prophecy, which came true a year later, and I don't think I have seen this kind of picture again. This was only one case where the Lima in the mid portion has got a severe disease. It is showing a good flow, and the LAD is very well opacified. LAD looks very clean in the mid and distal portion, but you can see the LAD showing a critical disease in the mid portion. The question here was to whether to address the Lima with a balloon and stent or go for a native circulation. The LAD was, of course, now a CTO, which was probably 7-8 years old. So we had to do a lot of work to get through this, and ended up with a very good result like this. So the left main is normalized, good flow to LAD. In fact, you can see filling retrogradely and good flows to the circumflex phloem circulation. So you have to be open which one to do, whether to do a native vessel. Like in this case, the Lima is horribly diseased over a long length. And I guess stenting Lima would not have been a nice option. Then this is a gentleman who had LAD which had a total occlusion, and the surgeon actually gave a double graft to LAD. One junction here carried forward the Lima and ended onto the distal portion. This was done because there were some big sized septors and diagonals, so they would be perfect with this. So there is now a critical narrowing here, you can see in this picture. And so we had to go through this jump graft. So this technically was very challenging because the stent wouldn't take a bend at the junction, and probably a part of the vessel was picked up in the stage. So we had to get the soft portion of the wire back, get the balloon close to the tip, just about a centimeter away, and over the soft portion we could advance the stent, and finally ended up with a good dilatation and stenting result this vessel. This patient actually had no other graft function, and you can see the LAD which is good, is also supplying the diagonal retrogradely and a lot of collaterals to the right coronary circuit. So I think a lot of wisdom will go in thinking which one to do, graft or the native graft. This was a 29-year-old bypass graft surgery done at Houston. And patient had 1 Lima, 2 LAD, and 4 vein graft. And this is the first time in 29 years the patient complained of chest pain. A very active doctor playing games and so on. And this is the occluded right coronary artery. And we did a CT which showed everything open except this right coronary which had a focal lesion. And then we took him to cath lab. I think CT angio is a very good test to decide in a grafted patient, because in one go you can study a lot of, get a lot of information. So this patient had unstable angina. We kept him on tirofiban for 2 days. After that, we did a CT angio, as you can see here, and then took him to the cath lab. Cath lab angio confirmed that all other grafts, including Lima, and the 3 other vein grafts were patent and very good looking. And this was the critical lesion. Fortunately, this was a focal lesion. So we have a distal protection device and worked on this. And you can see a nice result in the graft going to right coronary. And see the improvement in the RCA circulation. This is before and this is after, and you can see a blush also, which indicates that the microcirculation is well preserved. So distal protection device in a graft which is old like this is a very important necessity. And this was somebody who had multiple grafts way back in 1988. 10 years later, he got a stent to the graft going to the OM circulation, and this was also supplying the occluded RCA retrogradely. So patient was quite happy for next 10 years or so. And then he had a lesion in the graft going to the LAD. The LAD was small and occluded. The diagonal was probably taking over the supply to the LAD territory. And this is how we ended. You can see the Lima is good, and LAD has 2 distal lesions and also supplying retrogradely to a huge right coronary circulation. So doing this distal LAD through Lima was quite a challenge, but we worked through that, and we had 2 stents put in. We purposely took 2 short stents because this is how the Lima was, and taking longer stent through these tortuous Lima would have been very, very difficult. See the multiple loops of Lima, so better to take short stents, a stiffer wire, and probably a second wire on the side while working on it. However, we paid a price when we were trying to negotiate, and we ended up with a guide catheter section at the tip of the Lima. This was realized as we were taking some pictures, and it happened in the early part of the procedure, but we thought this was our only chance, and we continued to work on the deceased segment of the native LAD, and then put a stent in the origin of the Lima. And so this is the way we should have done it. We should have put a wire going towards the left hand, and so that the catheter doesn't dip much inside the Lima. So this is our final picture, the stents, the mid and distal LAD, and a huge retrograde supply to the PLV branch of the right coronary artery. So the distal protection is a little bit of worry because it has some additional steps and protection cannot be guaranteed. However, in a vein graft which are old, I think this is a very, very strong necessity. This is a case where lima is occluded, I guess after the surgery, but a big diagonal and a vein graft to the LAD showing a critical disease. So this is protection device, and then you put a stent, and you can see post-stenting result is good, and more importantly, the distal flows to septals, diagonals, and the occluded LAD are much, much better. This is a very fancy vein graft. The surgeon has actually created something like a left vein and joined another vein graft to that. And critical disease at this after some years. So in this kind of case, there is no consideration. It has handled, the grafts have to be handled. And this is how we did with a big diameter stents. And we have now 4.5 and 5 Medtronic DES. So I think they would probably come very useful in these kind of large vein grafts. This is another case where we have a doctor coming with angina. This is almost about 20 years after his bypass surgery. And the culprit was this disease in the PD after the bypass. So we went through the graft and then did a stenting here, and we got this kind of result. So you may have to either go through patient's native vessel or through the grafts and do a complete job. This is one case where we had to give up because whatever we did, we were unable to, we sucked out the thrombus, we gave intralesional GP blockers and also the enoxaparin. And despite everything, the flows remained very poor, some improvement, and we have to finally accept incomplete result. This was another case where a Y is done. The lima is going to diagonal LAD, and this was functioning well 7 years later. However, the graft between the Y and the OM1 was occluded, and OM2 and PD of RCA was also occluded. Only the mid portion of the graft was functioning. So this area was ischemic because this graft is blocked, and the right coronary area was ischemic because the distal portion of the graft is occluded. So what are you going to do? Open these or address these? Now the native vessels, I think we have enough experience, and we preferred addressing the native vessel. So we worked on the CT of the right coronary artery, and you can see the RCA is opened up nicely, the side branch. We used a drug balloon and not a stent. So the right coronary flows were very good. And then we put another stent from left vein to the OM1. This portion of the graft is functioning, so the OM2 also got a good supply. This portion is functioning well. Angioplasty to the left vein, OM1, was improving supply to OM1, OM2, and the right angioplasty side improved supply to a dominant right coronary artery. Now, this is the fate of some of the vein grafts. Like this was 10-year-old, but symptoms were recent. And you can see no flows in the vein graft going to the right coronary artery. A lot of discussion as to how to improve this circulation. The patient was too sick for a repeat bypass. So we worked through this vein graft, had this guide catheter, 7 French, go down the vein graft. When we were taking it down, we had a balloon placed at the distality of the vein graft and kept sucking as we went in. And this is the final result. So a graft, vein graft, which is 10-year-old, totally occluded, was salvaged, and you can see a nice flows in the right coronary vein graft restored, and it is supplying nicely the PD as well as PP, and the patient is doing very good with this. So which one to do is a big consideration. Now this gentleman was British, and he was also diabetic. So when we told him his angio is horrible, you can see the occluded right and a lot of disease in the left system, and we told him to go for bypass surgery. He was a politician, and within 2 months' time was to contest election. So he flatly refused the advice for bypass surgery. So we put multiple stents on him, 5 on the left side and 2 on the right side. The right was actually the culprit. And at the end of 1 year, we checked it up, and you can see a nice flows to all these 7 stents. A patient was a winner, not the angioplasters, because he's the one who chose the path, and this path worked for him. This is another case who had lima to the mid and distal LAD functioning. However, he had 2 big-sized diagonal which were not grafted, and a few years, 6 years after his bypass surgery, he had angina coming from a distality of left main, circumflex, and these 2 diagonal. So this was addressed with kissing SKS technique. You can see one stent going from left main towards LAD, other one going to circumflex, and then a few years later, he had an ISR with a lot of angina, and we had to address this ISR again with multiple stents, 2 stents. In fact, wired through these kissing stents, but balloon could not go through the LAD stent, so we had to finally crush the LAD stent, as you can see here, and then put multiple stents through this, and we got a good flow like this. So bypass patients will give you multiple options, and you have to choose the best option where you feel confident. This was a case where...
Dr. Hiremath, can you hear us?
Yes.
Yeah, I'm
Please
sorry,
summarize.
because we have now next session starting at 1 o'clock. Maybe, yeah, we have to start next session. Maybe you just summarize your great presentation, and then we
Yes, I think as the slide indicates, most conflicts should be resolved by discussion with the surgeons. If they are going to give more effective long-term results, I think we should allow them to go in for the case. But otherwise, a lot of things have happened in angioplasty arena, which would give you a good result, good long-term benefit. And I think a good discussion would probably end up with good results.
Okay, thank you. Thank you very much, Hiremath. Excellent presentation. Just final comment.
Thank you for great overview, and warm regards to you.
Thank you.